Good morning, students. Today we are going to see about the distal and radius fracture. This distal and fracture is very common in old age and in other age groups also, because this type of fracture occurs in even a slip and fall from while walking, and high energy trauma. Everything can cause a distal and radius. This distal and radius fracture is subjected to various distinct types of fracture, each with its own characteristic pattern of behavior. So this distal and radius fracture is very important because it forms part of the bone of a wrist joint. So hand is very important for any movement or what to say um, work a person has to do. So this distal and radius fracture, different types of fractures can occur in a distal radius. For example, Colles fracture, Smith's fracture, juvenile Colles fracture, radial styloid fracture, Barton's fracture, intra-articular comminuted fractures. These various types of fractures can occur in a distal and radius, and each has got a different pattern of trauma and different fracture lines and age groups. So in this class, we are going to see Colles fracture, Smith's fracture, juvenile's Colles fracture, radial styloid fracture, Barton's fracture, and intra-articular comminuted fractures. First of all, Colles fracture. This Colles fracture is a very common type of fracture which occurs in elderly persons. This type of fracture was first described by Abraham Colles in 1814. This is a transverse fracture which occurs in the distal end of the radius at the metaphysio-diaphyseal region or the corticocancellous junction. This is mainly an extra-articular fracture, but sometimes intra-articular pattern can also occur. Commonly, this is seen in elderly because of the osteoporosis of the bone, and you get a classical dinner fork deformity in this type of fractures. So mechanism of injury. A trivial fall on an outstretched hand with wrist in extension. This fracture occurs in the corticocancellous junction. Distal fragment of the fracture collapse into extension, dorsal displacement, radial tilt, and shortening. So whenever a person, mainly the elderly person, when he slips and falls, a trivial fall. Trivial fall is nothing but the old age people will be walking in the bathroom or somewhere, slips and then falls down. So to prevent the fall, what will they do? They will keep the hand to prevent the head injury or the head being injured, or to prevent the fall. So what happens is the wrist will be in extension and the fracture occurs at the corticocancellous junction of the bone, and the bone gets displaced dorsally. So what are the clinical features which you are going to see? So the patient always complains of pain, swelling, and deformity. And the patient's other complaint is inability to move the wrist because of the severe pain. So on examination, what you're going to see? So there will be a localized tenderness. Crepitus will be there. Styloid process tip will be at a higher level or at the same level of the styloid process. This test is called as the styloid process test. Limited palmar flexion at the wrist with severe pain. That means the movements will be, the palmar flexion patient will be able to do, but extension at the wrist joint will be very severe. So this is a picture which shows the normal radial height. A, the picture A shows the normal radial height. So whenever there is a fracture in the distal end of the radius, the B picture shows where the radial height is at the same level of the styloid, or it becomes still at a higher level. And this slide, in the top two pictures, you can see the deformity, the dinner fork deformity. And the classical dinner fork deformity, there are 6 components of deformity. So what are the 6 components? Component 1, dorsal displacement, dorsal tilt, radial or lateral displacement, radial tilt, impaction, and supination. These are the 6 deformities, classical dinner fork deformity, which you are going to see. Investigations, how you are going to radiologically, how you are going to investigate. So for the basic one is the radiograph. So you take a wrist X-ray, plain X-ray of the wrist, anterior, posterior, and lateral views. In that, what you can see is that there will be a fracture line in the metaphyseal diphyseal region. And usually this is an extra-articular fracture, but intra-articular extension or sometimes comminution can be there due to the osteoporosis. And then there will be a dorsal displacement, tilt, the radial tilt and displacement, impactions, and sometimes supination also can be. Apart from this, if there is an intra-articular extension, then CT scan will be helpful to plan for the treatment. In radiology, what are the normal angles which you can see in the wrist joint? The normal angles, if you see in the picture, the volar angulation will be always about 10, 11 to 50 degrees in lateral view, of the X-ray. You can see if you draw a line along the shaft of the radius, which passes through the wrist joint and the carpal bones, and another line intersecting the metatarsal carpal bones, and it reaches the distal radius. It makes an angle of about 11 to 12 degrees of volar angulation. And in anterior posterior view, you can see the radial angulation of about 23 degrees. If you draw a line from the medial articular surface edge to the radial styloid, and draw another perpendicular line across the articular surface of the ulna and the radius, it makes an angle of about 23 degrees. This is the normal degree or the radial angulation which is present. Another line is the radial length or the radial height. It is about 12 millimeters. From the articular surface of the ulna on the radius to the tip of the radial styloid, it is usually 12 millimeters. So whenever there is a radial tilt and a radial displacement, what happens? The radial height or the length is reduced, and the radial angulation is also reduced. Classification. So this type of Colles fracture is mainly an extra-articular but can have an intra-articular fracture. The classification which we use is the Frickmann's classification. So this Frickmann's classification is divided into absence of ulnar styloid process, and the other one is the fracture of the distal radius associated with the ulnar styloid process. So type 1 of Frickmann's classification, it is purely an extra-articular fracture of the distal radius without involvement of the ulnar styloid. Type 2 is extra-articular fracture of the distal radius with ulnar styloid process. Type 3 is intra-articular distal radius fracture, where the fracture line passes into the radiocarpal joint. Because as you know that there are two joints, one is the radiocarpal joint and the radio-ulnar joint. So in this type 3, the fracture line passes to the radiocarpal joint. Type 4 is intra-articular fracture of the radiocarpal joint along with the ulnar styloid process. Type 5 is intra-articular fracture, where the fracture line passes to the radio-ulnar joint without ulnar styloid process. And type 6 is the intra-articular fracture with ulnar styloid process. And then 7 is intra-articular, where the fracture line passes through both the radiocarpal and radio-ulnar joint with and without the ulnar styloid process fracture. So treatment. So whenever you come to a fracture treatment, there are two lines of treatment. One is the conservative line of treatment, another one is the surgical line of treatment. So in conservative line of treatment is nothing but close reduction and application of a POP slab, which for about 6 weeks for the fracture to unite. So this is mainly used in old age people where the comorbidity condition will not allow the patient to undergo a surgery. And then the extra-articular fracture, which is stable after close reduction. If you see, means the fracture will be held in the reduced position. It does not slip. It is not unstable. So any extra-articular fracture which is stable after close reduction, you can do a conservative line of treatment. Coming to the closed reduction technique. So closed reduction, as you know, the deformities. So there is an impaction, there is a supination, radial tilt, radial angulation, dorsal tilt and dorsal angulation. All these deformities has to be corrected. So the first thing is that you make the patient supine with the elbow flexed to about 90 degrees, and you need two persons, one person to give traction, another person to give a counter traction. So traction and counter traction is given to disimpact the fracture and to regain the radial length. Then what happened is we do a dorsal tilt and dorsal angulation. That means we flex the wrist joint to volar, and then ulnar deviation we give. So whenever you do a dorsal volar volar pressure and then a radial ulnar deviation, all the deformity is corrected. And this mechanism is brought up by the mechanism called as the ligamentotaxis. So ligamentotaxis is nothing but you know that whenever there is a joint, the joint is held by capsules and ligaments. So in this, the ligaments around the wrist joint. So whenever we give a traction and counter traction, the ligament will hold the fracture and it will reduce the fracture. So this is called as the ligamentotaxis. So this is a picture which shows the reduction technique and application of a POP. And the bottom X-rays shows the external fixator applications with plate and screws. Surgical treatment. So surgical treatment, you can do a close reduction with multiple K wires fixation. So you do under CM guidance, you anesthetize the patient, and then you give traction, counter traction reduced by closed manipulation, and then you pass percutaneous K wires from the radial styloid into the proximal shaft of the radius. Another method is close reduction. You can do a close reduction, or you can do a open reduction with mini external fixator application. Another type of treatment is the open reduction internal fixation with plate osteosynthesis. So plate means we can use a distal radius plate. Coming to the Smith's fracture. So Smith's fracture is nothing but the reverse of Colles fracture. This is same as the Colles fracture, where the fracture of the distal third of the radius is similar to Colles. Here there is a palmar displacement of the distal fragment, hence this fracture is called as the reverse Colles fracture. This is caused by a outstretched hand with wrist in flexion, or a direct blow to the flexed hand can produce a Smith's fracture. So this picture represents the Colles fracture. The first picture on the left side shows the Colles fracture, where the patient falls with an outstretched hand with wrist in extension. Smith fracture is fall on outstretched hand with wrist in flexion. Clinical features. So in clinical features, patient complains of pain, swelling, deformity, and painful wrist movement. On examination, there will be localized tenderness at the fracture site. A deformity will be present, but in Colles fracture, it is a dinner fork deformity. But in Smith's fracture, it's the reverse. It's the garden spade deformity. In the picture given below, you can see the wrist in the shape of the garden spade. Crepitus will be present at the fracture site, and the movement will be painfully restricted. Treatment. Again, as you know that treatment, both conservative and surgical line of treatment. So conservative line of treatment, you do a close reduction, and then POP is applied. The wrist is immobilized in an angle of about 30 degrees of dorsiflexion position. In Colles fracture, what you do is you keep a volar flexion and ulnar deviation. But in Smith's fracture, you keep the wrist in dorsiflexion, 30 degrees of dorsiflexion, and you immobilize the wrist for about 6 weeks. Surgical line of treatment, the same way, close reduction with multiple K wires. You can do close reduction or open reduction with many external fixators, and then open reduction with plate osteosynthesis. In plate osteosynthesis, You can put the plate dorsally, or you can put the plate distal, volarwards, volar plating or dorsal plating. Barton's fracture. The next entity is called as the Barton fracture. This fracture of the distal end of the radius involves the articular surface. It is the fracture, the distal end is split vertically in the coronal plane with small fragment getting displaced along the carpal bone. This coronal plane split can extend dorsally or palmar. As you can see in the picture, the first picture is the Colles fracture, where it is an extra-articular fracture and the fragment is displaced dorsally. In Spitz fracture, same extra-articular fracture, and the fracture is displaced volarwards. In Barton fracture, the fracture line starts from the articular surface and exits to the dorsal. It exits dorsally or volar, ventral. So whenever the fracture line exits dorsally, it is called as a dorsal Barton fracture. Whenever the fracture line starts from the intra-articular plane coronally and exits through the volar surface of the distal radius, it is called as the volar Barton fracture. So this Barton fracture is a highly unstable fracture, and this requires a surgical intervention. Close reduction can be achieved, but holding the fracture in good reduced position is very difficult. So open reduction internal fixation with plate osteosynthesis is recommended. So how you are going to do a close reduction? So whenever a patient comes to the casualty, you have to immobilize the wrist. So for that, you have to do a close reduction, relieve the pressure, and put a POP. So how you are going to do is you will always give a traction, counter traction. If the fracture, if the Barton fracture is a volar Barton fracture, you have to keep the wrist in volar flexion so that the capsules, the volar capsules and the volar ligaments relaxes and allows the volar fragment to fall in reduced position. In the picture, you can see the first picture. It is a dorsal Barton fracture where you reduce and keep the wrist in extension so that the fragment comes and sits in the position. Volar Barton fracture, you give a traction and then keep the wrist in volar flexion so that the fragment is relaxed and it sits on the reduced position. So the treatment is always a surgical line of treatment. So this picture shows the Barton fracture, the fracture line can be seen, and the reduction and the fixation with the plate osteosynthesis. So if it is a dorsal Barton fracture, you keep the plate on the dorsal surface. If it is a volar Barton fracture, you keep the plate on the volar surface of the distal radius. Next, we are going to see the radial styloid fracture. This radial styloid fracture is also called as the Schoffer's fracture or the Hutchinson's fracture. This is mainly an intra-articular fracture where it involves the radial styloid process alone. And it's commonly seen in car accidents, high velocity trauma, or fall from height, or a direct injury over the wrist. Clinically, there will be tenderness, swelling over the distal, radial styloid process and anatomical snuff box region. Radial deviation of the wrist is very painfully restricted. So this you can do a conservative line of treatment as well as a surgical line of treatment. Conservative line of treatment again is that you reduce the fracture and put a POP for 6 weeks. And if the fracture is unstable, that means you reduce it again collapses, then you do is open reduction internal fixation with multiple KY, percutaneous KY fixation you could do. Otherwise, you can do a lateral styloid process, low profile plate or screws. So the second picture shows the plate kept over the lateral surface of the distal radius. These small mini plates. Next type of fracture we are going to see is the juvenile Colles fracture. Juvenile Colles fracture occurs in children where the epiphysis does not closes. So here in this type of fracture, the fracture line passes through the epiphysis of the distal radius or sometimes through the metaphysis of the distal radius. This causes the juvenile Colles fracture. The same mechanism, fallen outstretched hand with wrist in extension, the distal fragment is forced posteriorly. Lesser force may cause buckling of the bone or torus fracture, sometimes a green stick fracture where one cortex is fractured, whereas the other cortex is intact. On examination, the same findings will be there. Distal tenderness present over the distal radius, swelling will be there, and then movement will be painful. Sometimes if the fracture is displaced, then you can get a tendon deformity over there. So here you take an X-ray, anterior, posterior, and lateral view of the wrist. So there will be an epiphysis separation. If you see the images of A and B, you can see the fracture occurs at the metaphyseal region where the volar cortex is intact, whereas the dorsal cortex there is a fracture. So this type is called as a green stick fracture. And if you see the images of C and D, it is a clearly a epiphyseal fracture where the epiphysis is displaced dorsally. So what you do is you give a traction, reduce, and then have to apply a POP. So whenever the epiphysis is involved, and if the classification, Salter-Harris classification, it is 2 and more, then the prognosis is not that good because there is a complete epiphyseal fracture and it is not reduced properly, then growth disturbance will be there. So ideally, these types of fracture, surgical line of treatment is the best option. If the metaphysis is involved and the epiphysis is intact, you can treat it with conservatively. But if the epiphysis is involved and there is a displacement, then you have to 100% reduce the fracture and then you have to pass smooth pins. So why smooth pins are applied? Because we don't want to injure the epiphysis, which is nothing but the growth plate. So coming to the distal end of radius fracture, what are the complications which we can see? So first, any complication, there is an early complication and a late complication. In early complication, circulatory problems and nerve compression, mainly the median nerve is involved due to the tight bandages and tight POPs. And then reflex sympathetic dystrophy. Late complications. In late complication, you can see malunion, delayed union, sometimes very rarely non-union, and then post-traumatic or post-immobilization stiffness of the joint, post-traumatic arthritis or secondary osteoarthritis, carpal tunnel syndrome because of the compression of the median nerve, tight bandages, and the retinaculums are tight. Then tendon rupture in Colles fracture, the most common tendon to get injured is the extensor pollicis longus because this tendon will come over the fracture site. Sometimes this gets ruptured. And then Sudex dystrophy is another late complications. So today we have seen about the fractures around the wrist and its complications. Thank you.